and then I'm going to bring up the slides if I can. Let's see, hopefully that's the final one. Okay, hopefully this is the one, because I was doing it last minute up until the call. So here we go. Okay, brilliant. So hello everybody again, and thank you for joining. This call, we're going to be talking about teamwork. And what I wanted to think about is how can we articulate teamwork on a global perspective? Because if you think about what the world has done, and that's both NHS, healthcare systems around the world, pharmaceutical companies, just look at the process, the progress that's been made in the battle against COVID-19. I think there's some good examples there that you will see in the media, and you can read about, and you can learn about, and you can look at. We're also going to take it down to the level in terms of what can you be doing now in terms of leadership, communication, and collaboration, especially in this virtual world that we find ourselves in. So before we go into this too much, what I'm going to do is just let you know that the educational content in this talk is obviously for the purposes of academic discussion and debate, which I think is really important, as I hope you guys do too. So please get involved as much as you can. You've seen this before, you guys will know me, but this is for people that don't. And I just want to say that the same disclaimer as ever, really, in terms of any views that are expressed in this are not representative of any of the associated organisations listed on the slide previously. So now that's out of the way, let's have a look at revisiting Monday's learning outcomes. But my slides aren't progressing. Here we go. So understand similarities and differences between different teams and teamwork, something that you did. Analyze theories of teamwork as well as reflected on your own roles in the team. And a big part of reflective practice involves thinking back, looking at it, and rather than describing what happened, thinking what would you do differently next time. So what I'd like you to do is go over to the medical student mess WhatsApp group that we've set up. Natalia, unfortunately, you're not in that because you're not a medical student at HIMSS, but feel free to chat and discuss while people are putting stuff in that group. And what it's going to be, it's 3 one-word answers in 3 minutes, and I will anonymize them and read them back into the talk as they come through, like we did last time. So the first thing that I'd really like you to do and put in that group is let me know, what team are you a member of? And I won't say your name, and I won't say what exactly, I won't apportion it to anybody, but I'd like to know an idea of what teams you guys are in. And you've got 60 seconds, so go. And that's for all of these. I know. Yeah, I don't know. But if we can do it as quick as we can, just get them all kind of piling in. What team are you a member of? Okay, great. So we've got netball, dance, cricket, netball, work, rugby, Melanin Medics Mentors. Somebody else typing, rugby, work. Okay, so lots of sports. That's good. HIMSS Gateway, yeah. Good, that's nice. That's a team. NA. NA? What do you mean NA? NA, okay. And then the next one that I'd like to think about is, what is the role that you play in that team? No, I know it's not applicable, but so yeah, what team are you a member of if you haven't answered it already, and what role do you play in that team? Player, okay. But what about position? So say that there's lots of sporting analogies there. I'd like you to think about the different roles and the different positions in those sporting teams and why it's important. Mentor and mentee, very good. It's the same names, guys, and there's 30 of you, and I know probably about 12 of you, maybe 15 at a push. So I'd really like some names of people that I haven't saved because they've new to the WhatsApp group and they haven't really contributed yet. The more you put into this, the more you'll get. Position, fly half, playmaker. Okay. So the thing I'm getting at there is in terms of, have a think of, are you a leader? Are you a natural leader in that team? Are you an appointed leader, such as a captain or a vice captain? And what are the kind of skills that you are developing in those situations that are relevant to you becoming a doctor? All right. So screenshot this slide, put it somewhere, take a photo of it. These are the things that I'd like you to think about. Some of you might not feel comfortable putting it in a WhatsApp group, fine. But you need to think about this for the rest of the talk because it's really interesting and it's quite a busy talk. Because the stuff that we're going to cover is this. And this is for you to come back, but I've also put it as stretch learning outcomes because a few of you that I've spoken to are taking that growth mindset and that point of view that you really want to get the maximum you can from the situation that we find ourselves in. And this is a great talk. Oh, nice. Communication and thinking quickly. Very good. Okay. Communicating with team and public. Great. Here we go. More stuff coming through now, so it's good. The reason that this is quite a good talk today for you guys is because we've got Em back, who did the neurology lecture, and we did the MS clinical history taking lecture. But there's so much that you can learn in this environment, Zoom calls, talking, engaging. And I have to say, I was a little bit disappointed on Monday where, fair enough, don't put cameras on, fair enough, not talk. Okay, fine. But this is a method where the more you guys put in, the more guys you will get to know each other in that group as well. And it's private, right? So it doesn't go anywhere. So I think I would encourage you to do this. Taking responsibility, used to do netball, striker, playing under pressure, fantastic. Work, optical assistant. Oh, I used to be an optical assistant and then optical advisor. And that's communication in a clinical setting. Brilliant, very good. So what do we think is the worst that could happen in a non-healthcare environment? And I'm not going to ask for an answer on that, but I'm going to put a link in the chat that I'd like you to watch. And I'm going to play it as well now, but it's not going to be on the screen because I couldn't get it working. But you'll listen to it if you can't see it on the thing. So the thing about Jordan Belfort is it's all true. I mean, let's go through some of the things in the movie. I got to say, I love the movie. You haven't seen it, regardless of the moral issues it raises. It's a brilliant movie. It's a very incredibly entertaining, brilliantly made. Scorsese for sure. And great actors everywhere. Matthew McConaughey, Leo DiCaprio, Jonah Hill. I mean, they're all terrific. But let's go through some of the stories. A female employee shaved her head for $10,000 in front of the baying mob of staff. True? True. To get breast implants, so it's sort of even worse. It was like the whole idea. To get breast implants, she shaved her head for $10,000. Yes, and I guess the philosophy was, her hair would grow back, and then it would all be perfect in 6 months. So that was amazing. The rationalization. I think that was it's interesting that you brought that scene because I think that was a scene that personally disturbed me, and I think it probably disturbed a lot of people when you see it. Did it at the time disturb you, or were you just too high? Oh no, no, it wasn't that it was so high, but it didn't start the way it started. We shaved a guy's head for $10,000, and that was really fun. Within a year, the head shaving was $50. Like the price went down because $50. Well, you become numb, and that's what happens with insanity and all this sort of stuff that you do. Where what seems amazing at first becomes commonplace after a while. You don't lose your soul all at once. You lose it a little bit at a time, incrementally. When I lost my ethical way, it did not start off. I'm sure we'll get to that later, but it's sort of like these tiny, imperceptible steps over the line, and before you do it. See, each time your line of morality moves a bit, and before you know it, you're doing things you thought you'd never do, and it seems perfectly okay. Same thing goes with the head shaving. So day one, it was, let's shave a guy's head, $10,000. He needed the money. It all made sense. It'd be fun, the crew cut, right? And then a year later, flash forward, and it's completely off the rails. Dwarves being thrown onto Velcro dartboards. Right. Well, did that happen? I wasn't there at the time, so I didn't throw. But you heard it happen after I left. Yes. What do you think about that as a? Well, I don't think it's appropriate for sure.
I mean, obviously, I think it'd be humorous to watch it as an outsider, but in a very bizarre sort of way. I don't think it's the sort of humor that you want to. Let's just say, I don't endorse the practice by any stretch.
It was said there was so much sex in your office, you had to have a sign above it saying "sex-free zone."
Right. Well, the problem with that is that we had all these young guys. Everyone was 18 to 23. And all the young girls, and everyone's making a lot of money, and there's a lot of drugs going around. So I don't think it takes much of a leap of imagination to figure out what happened next. And it started really with the elevator, and someone christened the elevator early on, and I look back at it now, and I can only scratch my head, and that I sort of, I would say, let's say I was instigating it in a way, not that I was responsible for all of it, but by being the leader, it becomes a reflection of what I was at the time. And that was it. So I take responsibility for it, and I wasn't even there for a lot of it.
Your number two, portrayed in the movie by Jonah Hill, ate a live goldfish that belonged to a Stratton Oakmont, the firm employee. Did that happen?
It happened.
You saw him do that?
Yeah, and the thing with that is that, his character was heavily fictionalized. He represents...
So the real life guy is who, really?
It's a guy named Danny. And in the movie, he represents a bunch of different characters. So in fairness to Danny...
But did Danny eat the
goldfish? He ate the goldfish, though, yes, and he's publicly admitted that. And
when you watch that happening, I mean...
It was...
the kind of nadir of broking excess, isn't it?
Yeah, no doubt. I think that, these things do happen on Wall Street. They just do, and insanity happens.
Are they part of the folklore, the legend, the kind of chest beating? Again, Gordon Gekko, whatever they. Is that what it's about? Really, it's about who can go the furthest.
I think that sort of behavior isn't just endemic to Wall Street. I think it's endemic to large groups of men who are drinking or doing any sort of, substances, or in a frat house or whatever it might be, where, people, it's like sort of the herd mentality, the crowd mentality, where people individually never do these things. You put 50, 100 in one spot, and all of a sudden the rules of behavior start to change.
Did you have a chimpanzee in the office handing out mail?
Not mail, just they had people had pets in the office. So there was an iguana, a rattlesnake, boas, all this sort of stuff.
You're saying this like this is all perfectly normal. If I came into my CNN office one day with an iguana, a rattlesnake, and a chimpanzee, I would be frog marched out of there high speed. You're kind of thinking this is perfectly normal.
I don't know. I heard some rumors that they have stuff in Silicon Valley. People they bring their pets to work, and they have all this sort of free. But for there, it's about free spirit, so they can be creative. I think we took it in a different direction here. So I don't think it was. I don't think the outcome was as healthy as it had.
What was the single most appalling thing you ever saw? Well, even you were.
So he goes on to say that he can't even talk about what the single most appalling thing that he ever saw was, and I'm sure you can imagine. But isn't that fascinating that you can look back at something and not see the warning signs when you're in the situation and when you're in the moment, but then when you look back on it, listening to that, it sounds crazy. It sounds absolutely crazy, but it's as he said, you don't lose your ethics all in one go. It comes in stages, and there was so much in that I think exemplifies some really interesting things that we can explore and look at and talk about. So from that, I'd like to move on to what is quality in fast food. And I'm going to just stop the share for now. And I'd like to bring Lydia into the conversation, because Lydia is obviously a Gateway student with us. Let's see if I can try and get that. What can you guys see? Can you see, Lydia, can you say something and just sort of maybe introduce yourself? That'd be really helpful.
Yeah. Hi, I'm Lydia, one of your classmates, obviously, and I work at McDonald's part-time on the weekend with uni.
And how do you find that, excuse me, in terms of balancing that? So being a medical student and working weekends?
Sometimes it's not the easiest, but I think it just forces me to be productive, because I know I have less free time. So it means that I'm more productive in the time that I do have. It just helps me be more organised, I think. If I had the weekends free, I'd end up just procrastinating, to be honest. So I think it helps me to stay on track.
Okay, fantastic. So what is it like working in that McDonald's environment? Have you got any, I know obviously everybody knows what McDonald's is, but they don't know what it's like behind the counter. What's the environment like?
It's a really fast-paced environment. It's very non-stop. Obviously pre-pandemic, we never used to close. It was 24 hours all the time. and it's generally really busy, like all the time. And it's weird as well because you work with people who've been there for 30 years and are managers, and then you'll work with people who, like me, when I first started was 16 and it's their first ever job and they're still in college and they're like a bit nervous and stuff. So it's a really weird environment because there's just such a massive range of people that you meet of different ages, uni students or people with families that are just trying to earn a wage. I've been there 3 years now and I'm a crew trainer, so it's my role to like train people when they're new and like coach people on procedures and help us to like hit target times and sales and provide a good experience.
Fantastic. So it sounds like it's really busy, and it also sounds like you're getting a lot of the skills that you will need that will help you in your role as a doctor in a few years' time. So tell us about how busy it can get at times.
Yeah, it can get quite intense, but we do have a lot of staff on when it's really busy. So it's just all about working together as a team, really. Everyone has their own kind of responsibilities and things that they're in charge of. And it kind of works like a big machine. Like everyone's like a cog, like doing their own bit. And then when you put it all together, it produces like getting the food out, I guess, and making customers happy. But it is all about like communication, I guess, like, and just working together, like, because you just couldn't do it by yourself. Like I think that's something I've definitely learned, like from working there. You couldn't make up a meal on your own. Like you need everyone to work together and do their part to get the outcome.
So it's the logistics, the steps in the process, I like your analogy, the cogs in a machine. If all it takes is one cog to be slightly off and it can mess up the whole thing. So do you have any examples in terms of how, as a leader in that environment, do you make sure that the cogs are greased and oiled appropriately so that the team functions well?
Yeah, so I find it's all about like keeping people motivated and rewarding people when they've done a good job. With it being like so like stressful and full on at times, I think it's really hard for people to lose motivation and just feel like it never ends. So we always try to recognize people when they're doing a good job, whether that be that they can just get a free flurry on the way out or a tub of sweets or something like that. And I think it's important to just recognize people on shift as well when they're doing a good job. And if you see someone that's struggling, it's really important to send someone to help them if we have someone available, because the whole thing will just fall apart if one person, say like on the fry station, if someone runs out of fries, then we can't get any meals out. So you've got to send someone on to help them recover their level and get back on track. So I guess it is really all about teamwork and working together.
And when that happens, the unexpected, what's the pressure like in that situation, and how do you cope with that?
It is very full on because obviously when it's normal, you've got maybe like 20 people stood on front counter just staring at you, staring and looking for their orders and waiting for it to come. So it can feel like a lot when you've got like all these eyes on you and you've got no fries there, but it's just about trying to remain calm in the situation and asking for help when you need it. We have like what's called a danger zone, where when you've gone into that danger zone, you're meant to ask for help. And so we generally do that, and that's what like stops everything from falling apart, basically, everyone following that
danger zone thing and the training that you get to that point, right?
Yeah, exactly.
Fantastic. So that is something else that we're going to talk about in terms of simulation, which you will all get obviously as medical students and from your training in that point of view. But just to wrap this part of the talk, Lydia, how has working there in McDonald's for the last 3 years helped you understand how to develop yourself and the skills that you need when it comes to a customer facing role or a public facing role? Because I think the reason that this is so important for medics across the country is that is sometimes lost in the reams of material and academic literature and stuff that you've just got to churn through, that ultimately we're putting you through a process that will mean that you as future doctors will be in a position to communicate with the public in a meaningful, compassionate, articulate and also correct way. It's vital that scientific communication is done in those terms. So how have you might not have thought about it, I don't know, I don't want to put you on the spot, but what sort of skills do you think you've picked up in that environment?
I think like working there as long as I have, it's definitely helped me to develop how I talk to people that I don't already know. I see a massive range of people working there, 6 a.m. meeting like workmen while they're going through drive-through for a coffee, families at midday with lots of kids and like dealing with complaints, or whether it be drunken people at like 1 o'clock in the morning. You really do see it all. So I think it's definitely taught me like how important it is to change the way you communicate with someone.
Have you got any specific examples about how you change the way you communicate?
Yeah, so like say if someone comes in and they're pretty angry because we've missed off a burger on their order, or something's wrong, or we forgot their sauces, it's really important to try and be understanding of their situation, apologize, and like understand why this would be frustrating for them. Like it's definitely taught me that even if someone's shouting at me, it doesn't mean that I should be shouting back and like giving them what they're giving me, because it's not going to solve anything. It's better to try and understand the situation and resolve it calmly.
Yeah, fantastic. So it's taking the adrenaline out of that process, isn't it? Because when you will be working in A&E and you'll be asked to you'll be in those kind of situations where somebody's shouting, somebody's complaining, and there's always, whenever somebody makes a complaint, there's always something underlying it that's driving that and that's causing a problem. So as you said, Lydia, if you can remain calm and lower your tone of voice and think about your body language, those verbal and non-verbal cues, then that will be really helpful and really important. So thank you so much for offering and volunteering to do this. It's very helpful. It saves a few more slides that I make and also have to make, and also makes it more engaging and more relevant for your peers. So thank you, Lydia. If we were in the real world, I guess we'll give you a round of applause, but I think that's a little bit weird and naff when people don't unmute. So you can put your comments in the chat. Thank you very much, Samar. Yes, you can show everyone's favorite manager. I would come to your store if I ate McDonald's, Lydia. So thank you so much. Well done. That was really, really good. And pleasure. So I'm going to go back to the slides now. And let me know if you can see them. Here we go. Can you guys see that? Yeah?
Yeah, we can see it.
Brilliant. And then, hold on, stop that, start that. I don't know where video's gone. Give me 1 second. There we go. Fine. Okay, so if we think of high performance teamwork in healthcare, surgery is a pretty good example of that. And the most extreme examples that you'll have seen in the media recently are the ones where, do you see somebody recently had like a double arm transplant and face and double arm transplant? He had a team of about 400 doctors. So that is absolutely phenomenal in terms of all the different aspects of communication and teamwork that are required to get the donor organs, to harvest them, procure them, keep them safe in storage, get them to the place where they need to be. At the same time, in parallel, prepping the patient who's going to undergo the transplant for surgery. You've got donor teams and recipient surgical teams, anaesthetic teams, the support staff behind that. It is so dependent on teamwork, and everybody, as Lydia very rightly said, being cogs in that machine. It is absolutely essential and vital. So that's one example of high performance in healthcare. Another example is the golden hour in healthcare, which I was incredibly grateful to receive on the 14th of September, where, as you remember in my first talk that I gave you 3 weeks after the accident, and if you watch that back now and you look at how I communicated in a different way because part of my brain had been shut down for various reasons. But when I was being scraped off the pavement by some paramedics and the air ambulance crew, my memory from that is quite vivid. And it shows that the importance of communication when you've got a patient in that kind of situation is actually vital. Because I can remember a paramedic looming over me with a mask that had a Liverpool FC thing on it, and they joked and they said, yeah, we've cut off your Watford shirt and all your kit because you beat us last year, so we've got rid of that for you. Don't worry about it. But the people that were involved in that golden hour of healthcare, where something happens and somebody's life is potentially on the line, is amazing. The years of training that those HEMS doctors and pilots and nurses on that helicopter would go through put them through an inordinate amount of strain on their body. I know an old ex-HEMS doctor who's quite young, but he's got arthritis in his back and his knees and all over his place. So there's a tremendous personal cost, but then there's also a tremendous power in when you put together high-performing teams and professionals who have a common cause, have a vocation, and put everything that they can behind it. The results are spectacular. I'd like you to introduce you to this concept of X-team methodology. And an X-team is basically a highly functional team or group of people that are placed in geographically dispersed locations around the world. And they may never meet each other physically. They only meet each other physically if they need to. But the beauty of, if you have organization and communication between these people working around the world in different time zones, and they have chains of communication and they pass it across to each other, you could work 24 hours a day. You, as businesses and organizations and healthcare systems, you could actually work all the time. So I just wanted to say the X-team methodology there, and certainly in drug development in a time as now, where we have to find treatments and vaccines for COVID-19, then that is a nice example to think of X-team methodology. If it interests you in terms of that kind of team working methodology, look it up. But it's definitely a stretch goal. So you might be sitting there, or hopefully standing there, or outside wandering around, whatever. But you might be on the other end of this Zoom call thinking, okay, that's great, but that's 15 years away. And right now I've got problems that I need to deal with, like exams or stresses of pandemic or various other things. So you might be thinking, how do you build these skills? And what I would move on to and say is, well, we can help you build those skills for you. And this is how we can do it. Simulation, practice in a safe environment. And I would really, really, really encourage you to start seeing these Zoom calls as a safe environment, where obviously I'm not just going to pluck Lydia or any of you from thin air and say, okay, off you go. There comes a preparatory call before. I can't say that, but prep call, we'll say preparatory. Okay. But there comes preparation beforehand. There comes a call, and these virtual interactions in environments are an absolutely massive opportunity for you and how you are going to go off and practice healthcare. And it is akin to what the medical students in the years before you did in simulation suites, putting in catheters on models. You can't cause any pain catheterizing this model. But I tell you what's fascinating to see, having trained and taught hundreds of students, maybe thousands even, going through this, it's fascinating to see that as soon as you try to practice these skills in an environment that's a little bit unnatural, your behavior changes. You're actually worried about, as you're holding the penis, putting the catheter in and not pushing too hard. And that's okay. That's fine. You have to do that because that's part of the process to build you up. And then once we do that, it can be purposeful practice. These were a group of my students 4 or 5 years ago when I got asked to teach them how to scrub. I was like, okay, yeah, fine, we'll teach you how to scrub. But I refused to do it in an environment that didn't mean anything to them. So I got a theatre that was out of commission for the day because it was getting, I don't know what's happening to it, but you'll be pleased to know that there was no patients being operated on at the moment while we were in there. But putting them in that environment where they can practice the skills that they need purposefully was really, really powerful. So just have a think about that and how you can identify opportunities at your time with Hull York Medical School, not just now, not just this today, this lecture, this semester, this year even, but over the next 6 years. How can you actively seek out opportunities that will build you guys up in terms of what you need to do in the future? So I was going to tell you a little bit about my journey. 2005 this was, so I was just waking up here wearing a POG t-shirt. For those of you who know what that is, that's passion, orange and guava. It's like a cap that would used to go on drinks, and it was a game that we used to play. So I'm 19 here, so same age as you guys on the call. I just moved into 16 Eastleigh Road in Leicester, which also happened to be the house that my GP lived in as a medical student when she went to Leicester. And she had a completely different experience where she would have an operating list of her own as a medical student, and the boss, the consultant, would be next door and she could come in. But if you look at this, this is ground zero in terms of my medical training. Firstly, I was in an environment that I was comfortable in, because when I was a medical student in the first year, unfortunately, somebody sadly killed themselves, so lost their lives, and I found them. So this is a year after me probably suffering, well, I say probably, that's trying to speak it down, definitely suffering post-traumatic stress disorder. For a year, going into the shower, I was jumpy. I didn't like being in the dark, didn't like sleeping. And that was quite a powerful experience. So the reason I say that this is a safe environment for me and a safe space, and I still look back on that front room, that office that I had for 10 years, because I was very lucky that my parents bought a house with a mortgage, that they provided an environment for me to thrive rather than just survive at medical school. And this is ground zero, because I was just starting out. You can see the shelves are empty. I've just woken up. I built the stuff last night. Well, I didn't build the desk. I didn't trust myself to do that. So I got somebody in to do that. But I certainly built the shelves. And I was just waking up and having a Skittles breakfast. Now, that's not particularly healthy if we think about the sort of things that we need to be doing, because as doctors and future doctors, the environment that we place ourselves in, we have an absolute responsibility to make sure that everything that we put in our body, whether it be food, environment, sound, anything that goes in has to be keeping us as fit and healthy as possible, because we are going to go into situations that we need those reserves of strength. So the reason that I was getting away at 19, eating Skittles maybe for breakfast, I don't know, Maltesers, whatever, other confectionery is available, was because I was so young that my metabolism would burn all that off and it was fine. I tell you what, if I did that now, that would not happen. I just wouldn't do it, because that's a fact of aging. And the next slide, there's a gory photo incoming, because so this is a serious warning, if you don't like seeing blood, I would 100% suggest you look away, because the transferable skills that I gained. I couldn't hear what you said. Okay, don't worry, Siri. I think you'll be fine looking at it, but we'll see. So the transferable skills gained from the simulation, from the learning how to suture and stitch and operate on people, firstly in a safe environment and then in a clinical environment, were very useful when I was seeing things like this. And so this patient, who I'm eternally grateful to for allowing us to share this image for the benefit of training you, the future, unfortunately suffered quite severe injury. And that is actually skull. So that is down to skull. So quite an elderly patient, quite thin skin. The scalp is, as you can see, very vascular. But then there's a trade-off here. Do we send them to theatre, or do we do it in A&E? So depending on, because I took an interest and I wanted to be a surgeon and I took the time training, that meant that I was able to put it together safely in A&E. But that's not always the case. So everything that you can get, that's for various reasons, problems with the injury, the skill mix available at the time. And I needed help on this, not from a surgical perspective, but I can remember my consultant. I wanted some local anesthetic called xylocaine that had adrenaline in it as well, because adrenaline is a vasoconstrictor. And that means the blood vessel closes, it shuts off a bit, so it stops bleeding. So it helps me get a clear surgical field where I'm putting this patient's scalp back together. And obviously, I need to do that as quickly and cleanly as possible because I'm not in a sterile environment like theatre, and I want to minimize the risk of infection. And one of the ways that I know that I can minimize the risk of infection is to have that special local anesthetic with adrenaline in. And when I was asking for the pre-made up vial of xylocaine in A&E, they said, oh, we don't have any. I was like, oh, no, I can't do it then. And I spoke to the consultant. He goes, no, just make it up yourself. I was like, what? He goes, God, come on. So he showed me how to make it up and make your own. And I still wouldn't trust myself to do it in terms of the numbers and the maths, because I've only seen it one time at that point. So another part of this is recognizing the limits of your competence. And the other thing is one thing leads to another. We've been forced into a digital age, but this was my studio set up in Lincoln, I don't know how many years ago. I went to Lincoln in 2013, and this was probably 2 years after that. So maybe 2015, say. This was my studio setup. Mobile Wi-Fi router. I think it's because I was moving out of the house here. That's why it was so tidy. Everything was in storage. I just had the desk. So it was probably actually maybe 2018 if that was the case. But it's regardless. It was a few years ago. But look how minimalistic the kit is to do a broadcast. So this was a radio interview. I can't remember who or where. I think it might have been. It was about debating personal health budgets. So I think that was talk radio. So it was setting it up, iPad or Mac, electric power, tripod, speakers, audio line, so that I can have audio in the ear and communicate. And who knows that would have led to this? So that's what we did in lockdown when we wanted to test. Well, not just in lockdown, it was in July actually. So it was after lockdown, but we wanted to test how could we film in a COVID secure way. So that means 2-man teams or 2-people teams, 2-person teams, because you're minimizing the amount of people. So there's no runners, there's no people to lift all this stuff up the stairs. We didn't go into the lift because that's an infection risk. Dave did an absolutely smashing job, wearing a mask, wearing a visor all day, very difficult. But if you look at this slide, okay, that was broadcasting, do it yourself, but still getting out to people. That is doing it professionally, but still with one other person. And also, this is Jack, who I've mentioned before. But some people might look at that and laugh and think, sleep on the job, it's terrible. The other important thing in terms of high performance is knowing when you need to rest. And he's listening there. I know he's listening, because every now and again he's concentrating on what he's needing to do. He knows his stuff so well that everything is set up, everything is running in unison, in parallel, and in harmony. So he's taking that moment to rest and relax. And as doctors, we're terrible at doing that. As I said that before the call, I've said that my sleep before these talks, because it takes a lot to pull them together, is not great. But I get so much from doing it, I don't mind doing it, and I'll catch it up afterwards. And then as for those of you on the call earlier, right, who would have thought that would lead to doing it yourself? But then also, just before we came on air, one of the producers at Sky, Saffron phoned me saying, oh yeah, actually we'd like you to come on the audience tonight with the program that they're doing, which is learning the lessons from the pandemic with Sophie Ridge, where there's a live where there's a live, I say studio, but a live audience. So wouldn't it be great to see you all there? You log in on YouTube later, you can text me your questions or tweet them, and the things that we're talking about now can become reality for you later on. So your exposure to media and medicine in a safe environment, a lecture like this, can be extrapolated just by chance, because it just so happened that 3 or 4 minutes before this call, they phoned and said, yeah, okay, we want you. So the other lesson there actually is you need to be ready to go. You need to be ready to go, both in medicine and media, because you never know what's going to be around the corner. So what I'm going to do is take you back to the WhatsApp group, please. And I would like you to tell me, what does quality in healthcare look like? So 3 words in 1 message in 60 seconds. And then while you're doing that, Em, what do you think quality in healthcare looks like?
Okay, I've just had to switch devices because, actually, hang on a minute.
No worries. If
Yeah.
or Paul, if you're in the middle of something, but okay.
Quality in healthcare looks like.
Or it doesn't have to be in healthcare. What does quality look like to you?
Something that's streamlined, something that's effective, something that delivers the outcome, repeatable, adaptable to the situation, responsive to individualistic needs, cohesion within the team that you see working wherever they are, be that McDonald's. By the way, everybody should watch The Founder, because then you work out the amazing logistics that were invested within McDonald's. It's a fantastic test bed for any transferable skill. Lydia's got the best place ever. Quality is repeatable outcomes, repeatable actions to deliver the highest standard possible. And when you've got a highly variable situation, when you're working with a person, you've got to have that foundation of conscious competence and subconscious or unconscious competence to be able to respond sympathetically at the time of which you need to deliver, and know where your boundaries are, know where your role stops, and where you change from being the lead person to being an observer, to being a facilitator, to being, how you can play your role within that team.
Fantastic.
Yeah.
Thank you so much. That's really good. And so while you were talking, the things that came through were time, patients feeling cared for, efficiency, patient-centered care, communication, and again, patient-centered care, caring, patient satisfaction, patients being seen as humans, not names on a schedule. And that got some upvotes, or the equivalent of a WhatsApp upvote, and I agree. Understandable, reliable, satisfaction, collaboration, care, reliable, care beyond illness. So I'm sure you can understand that there's various shades of grey in between all this. I think it's quite clear, maybe not in the moment, to understand what bad care is, whether you're both a patient or a doctor or a healthcare professional. But I think it's fair to say that the extremes of this, in terms of what is the best gold standard, golden hour trauma care, scooped off a pavement, sent into A&E, live, brilliant, and medical negligence, or more sort of malign things, but the polar opposites are fair to see, or are there to see for everybody. And what I'd like to introduce you to is crossing the quality chasm. I guess that's how I'd say that word. I don't know, I haven't had to say it again since, but it's a framework for quality in healthcare, and it's a new system, a new health system for the 21st century, and it's by Don Berwick, and it encapsulates in these 6 things. It's got to be safe, i.e. avoiding injuries to patients from the care that is intended to help them. It has to be efficient, avoiding waste, in particular waste of equipment, supplies, and these are the 2 really interesting ones, ideas and energy. Because as healthcare, we take some of the brightest, best, most talented, altruistic people of their generation, and then we put them into systems that grind them down and break them down so that they can be on the verge of burnout, and they really don't care, potentially, in terms of, well, even their own energy, their own ideas. So if they're not looking after themselves, how can they be in a situation to look after others? It needs to be effective. And that means avoiding underuse of effective treatments or overuse of treatments in people who are unlikely to benefit from them. It's got to be patient-centric, and that is providing care that is respectful of and responsive to individual patient preferences, needs, and values. It needs to be equitable, which is providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and or socioeconomic status. And it needs to be timely. It needs to be timely because reducing waits and sometimes harmful delays for both those who receive and those who give care is obviously going to be beneficial for all involved. So given the examples that we've talked about, given the fantastic overview of transferable skills that Lydia has demonstrated, and then the articulation into more of a sort of business and commercial environment that Emma's given us, I hope you will all agree that what we are talking about is not easy. Far from it. It's incredibly complex when it comes to both systems change and the people as individuals operating in those systems. So there's a lot of personal responsibility you can take, but there's also a lot of support and structures and other things around you that can help. And one of those things that I would suggest that you look at and you invest some time in and seeing is this book called Rebel Ideas by Matthew Syed. Now, Matthew Syed is ex-England table tennis champion. He's a writer for the Financial Times and a journalist with the Times as well. And in this book, he's written a few, and I've mentioned them before, but in this book, he's talking about the power of diverse thinking and why cognitive diversity is absolutely vital. And the first page is a little bit of the prelude to 9/11. And 9/11 it's only when you're looking back on it that these collective biases and these collective blindness or collective blind spots are actually apparent and there for all to see. And this slide is the most important one of the talk. And it references the book. If you were to buy it, it shows you which book to go to it. But I'd like to spend a couple of minutes just talking through this slide. And I know it's busy and there's a lot on it, but it's really important. So you can have one, which is an intelligent individual, but they only have a subset of knowledge. That could be Lydia working on her own, not wanting to collaborate, not wanting to bring others on around her, not wanting to share her knowledge with the team so that you can have those cogs in the machine. I don't think it would be Lydia, I hasten to add. I think it could be, just using that example. Could be a team of clones. And that's type 2 of teams, where you have lots of smart people, and this is medics down through and through, lots of smart people, and it's comforting. It's nice to be around people who think the same way because it makes us feel safe and it validates our worldview. So that's not great necessarily, because if you think of the box around all this as the totality of knowledge. So even with a team of rebels, as Matthew talks about, where there is a good coverage of knowledge, where they're getting close to the outer limits of knowledge in that box, they're still not covering everything. And when it comes to complex ideas and complex solutions and complex problems, there is no better time to recruit an ex-team of people that I often do. That's why Natalia's on the call. We've never met, but she's come together for this because she's adding inherent value and a different mindset to this. There is never a time, really, not even complex problems. I work all the time. Anything that I do, I will actively seek to work with people that look at the world in a different way to me. And then the fourth one is rebels without a cause, which is a disaster, clearly, because successful teams are diverse, as Matthew puts it, but they are not arbitrarily diverse. The key is to find people with perspectives that are germane and synergistic. So that's the common cause piece. And then 5 is a diverse team with a dominance dynamic, where under a dominant leader, so just say Lydia was in McDonald's and shouting at people and saying, I want you to do it my way or the highway. Again, I cannot imagine that, Lydia, at all. But what you would happen in that situation is you would get basically lots of subordinates who don't say what they think, but what they think the leader wants to hear. So that's not very good either. And then finally, a team that begins to parrot the leader. And basically the ability of the team to be like this is diminished. And I don't know if you can see my slide or my print pointer, but the team of rebels, so I was pointing towards the team of rebels, has gravitated back towards a team of clones. But it's even worse because they're just basically, yes sir, no sir, how high do you want me to jump? 3 bags full, sir or madam, but generally sir, because of the phrase, right? So this is the most important slide we're going to talk about today. And I would like you to print it or draw it out or put it on your wall, because I will revisit it and I'll come back to it. And when we have our one-to-one mentoring sessions and we chat to each other, and you come back to me with scenarios that you face, I'll say, well, is it team 1, team 6, team 5, team 3? How can you move from team 2 to team 3? What do you need to do personally? What other resource do you need to recruit and get in to help you develop that? So I really hope that that's useful for you. And then, so the 6 quality factors to strive for excellence in healthcare are clearly listed there. I would say there's a 7th, which is communication, which is the communication that links all these factors together. Because if you don't have communication, any relationship will break down. Personal relationships, professional relationships, and relationships in teams. Because teams that don't communicate well do not put patients effectively at the center. Far from it. They become that team of clones with a leader that they're gravitating towards and that they're dominant leader. And if you think of all the knowledge of the metrics of quality in healthcare around the outside, look how close to the center they are, where they're not getting a diverse perspective. They're not getting a 360-degree view. So if you make a team of rebels that are oozing cognitive diversity, you really can put patient care in the center of everything that you do. So I'd like to, if people could go on mute, please, I'd really appreciate it, just because it puts me off. I don't mind, it doesn't matter, don't worry. I get life happens, it's absolutely fine, but that'd be really helpful. What's the worst that could happen in a healthcare environment? Wow, mid-staffs is the worst that can happen. So this happened in the UK very recently, and this clip was published on the 6th of February 2013. When it comes to appraising and critiquing media, especially as it's all swirling around on social media, you don't know where it's coming or what direction it's coming from, I would suggest you look at the source, so The Guardian, so you know what kind of slant they might want to put on things, so you know which direction that the media might be pointing in, and then test your hypothesis. Look at the information in front of you and think, okay, I thought it was going to be, I don't know, very left-leaning, for argument's sake. Is what you hear left-leaning? Or is it in the middle? Or is it fair, balanced, and accurate on both views? Because whatever your media source, it is absolutely vital, it's absolutely critical that you think about what you're expecting to see and hear, and you have a diverse view, and then you listen to what you see and hear, and then you self-test that hypothesis and see. It's the same as critical appraisal and clinical reasoning, but in a different media environment. So this was published on 6th of February 2013 by Dennis Campbell, and there's a little video here which I'd like to play. And there's a little bit of a delay here because I couldn't get the recording properly. But don't worry about all the tabs on the top. They are 100% under control.
Today will be, what some people have already said, will be one of the darkest days in the history of the NHS. We're going to get the results of a 2.5-year mammoth public inquiry into care at Stafford Hospital between 2005 and 2009. care was so bad that between 400 and 1,200 people are estimated to have died as a result. What I think Robert Francis QC will tell us today is that there was total system failure in the NHS. And he will basically say the NHS needs to pull together as never before to put in place an early warning system and an early intervention system to make sure we never have anything like this again. You had particular failings, appalling, horrific care at one hospital, but a whole range of bodies and individuals who are meant to detect that there were problems, take them seriously and intervene to stop them happening, didn't do so. Crucially, we're going to get named properly for the first time and shamed people who, at various points in the NHS system, failed to notice what was happening and or to do enough to stop it. The government's response to this, led by the Prime Minister David Cameron and also Jeremy Hunt today, will tell us a lot about how the government sees the future of the NHS. Today will be a day of reckoning and reputation shredding for a lot of people from the local NHS to the top of the Department of Health in Whitehall.
So let's think of some of the language there. Today will be a day of reckoning and reputation shredding. And there's some other stuff which I didn't make notes, I can't remember, but it's quite interesting. Naming and shaming. These, if we look at this from a journalistic point of view, this isn't actually that helpful, to be perfectly honest. This honestly isn't that helpful, because what we want is we want people to speak out. We want people to improve quality in healthcare, but we also need to create an environment where it's safe for them to do that. So I'm just going to go to this one. So if I haven't been able to convince you and persuade you as of yet as to why teamwork is important, the story of mid-staffs was one of poor management, bullying of staff, cuts to nursing staff levels to save money, and an obsessive focus on senior managers on meeting government targets. We need to move away from this situation where people in responsible positions feel they can't say what they genuinely think is good for an organisation in whatever setting they're in. And it's vital also to not just look at that analysis of that, but also the media's portrayal of that analysis. As I said, it's got to be fair, it's got to be balanced, it's got to be accurate, it's got to be referenced accordingly in terms of sources. But then also that's the media responsibility angle on it. And as a medical journalist, I look at that and make sure that any content that I put out fulfills those beliefs. But then there is also a responsibility on the individual to critically appraise, critique what is put to them. And equally, if I say stuff on these talks that you don't agree with, if you feel comfortable to raise your hand, do it, and we can bring you into the conversation. If you don't want to be recorded, text me, talk to me, say, actually, Kish, you said this and I don't agree with that. This is not some kind of Professor Reg Dennett used to tell me about whether lecturing is whether lecturers are seen as some kind of sage on the stage or a guide by your side, and it is definitely in my mind the latter. I don't want this perception to come across that, oh, just because Kish says this and he's our lecturer, he said this is true. No, that would not be cognitively diverse. I would like all of you to test what I say and think and say, okay, well, what's his biases? What's his experience? Why is he coming to this from this perspective? And ask the questions, because it is only through that, as a healthcare professional, that we will be able to stop the next mid-staffs. I promise you. And you are all a vital part of that. So me staying up till 2 o'clock or 1 o'clock, it was only 1 o'clock actually last night, because I learned last time when I stayed up till 2 o'clock, and I wrote off a whole weekend with bad headaches. I modified my behaviour a bit. It got a bit better, but still not great. But anyway, what I was saying is that if I can help 1 or 2 of you go on and make a contribution that helps other people go on and make a contribution, and the net aggregate effect of all of that is that we can play parts and we can be cogs in that wheel to stop this, and it stops 1 person dying, then it would be worth it. So this is a slide that talks about the different types of communication. And I'm not going to go into it because we're running out of time, but it's a useful thing. It's a useful framework and a metric for you to look at and think about when you're in an environment, whether it be with a patient, friend, colleague, family member, whatever, or observing communication in the external world. on whatever media source, just have a look and think, what kind of debate is this? What kind of communication is this, and why are they doing it? What are they hoping to achieve? Are they hoping to drive clickbait? Are they hoping to be deliberately controversial because they've got a monetary model, a business model behind clickbait that helps that be the case? Is it helpful dialogue between doctor and patient where they can come to a shared consensus? Is it a bit of a diatribe? Is it a bit of a rant? The classic one that I experienced was when I was a junior doctor. Can't remember what I was. I wasn't a consultant, but maybe an FY2, maybe it's a second year doctor. And I came in touch with a radiologist, and I was trying to get a neurology scan for a patient. And the first start was, I'm not going to talk to you. You're not a consultant. So I said, well, how am I going to learn? How am I going to do the referral if I never get the opportunity to do it? And then I'm a consultant and I haven't had the skills and the training. But that radiology, he didn't care about that. He didn't care at all. He cared about his individual work-life situation. Yes, he was probably under stress, aren't we all? But that's not an excuse. That's not okay to start a conversation. I don't want to talk to you because you're not a consultant. Come back to me in 15 years. For that neurology patient, that wouldn't have helped. And then when I browbeat him, because I went back into diatribe mode to counter that, and I finally, this guy graced him his time, or me with his time, to give me his presence, and I was explaining the symptoms of that neurology. I didn't do the best job in describing it because it was quite a hostile environment to start off with. So I didn't best represent my patient's symptoms because I was in an environment where I couldn't. And I'll always remember the flippant comments like, oh, that is an interesting type of neurology, isn't it? And, in this case, it wasn't a weird and wonderful diagnosis. It wasn't something like MS, which as we know from M, it was genuinely just, I wasn't in a position where I could articulate properly and fairly. So I'd really like you to think about this, the forms of communication piece. This is why it is relevant to your course and to the journey that you're on to becoming doctors. You have all the tools. You have absolutely all the tools. And I've used this slide a number of times as well. And the thing that I'd like to use it to represent today is, do not be lost in the woods, forgetting about what is at your disposal, the opportunity that you have. You want to be in a way that is helpful for you, because I've already talked about the dangers of tech and the way that it hacks your dopamine pathways. But that's not to say don't use it. It's saying be aware of it. Use it in a safe and responsible way, because I would suggest it is far better to be on the information superhighway rather than stuck in the woods, in the dark, isolated, cold, lonely, not knowing what is happening. And this is the best example of this. This is Dr. Jim Moore, who's the president of the Primary Care Cardiovascular Society. And obviously you'll know Lydia. You won't know is Enrique, who is, I don't know if he's on the call, but he's a graphic design specialist that I work with. And I had a catch up yesterday with Lydia, just a quick touch base, just to make sure she was happy for this talk. She knew what she was doing, and we were in good position. And work called, I had to do this. And so instead of closing the call down on Lydia and saying, I'll call you back or whatever, I said, okay, yeah, just come past my equivalent virtual desk, Enrique. And so Lydia got to find out about the Primary Care Cardiovascular Society and an introduction to heart failure and ejection fraction and all that sort of stuff. So I guess what I'm saying is the tools are there, use them to your advantage, because she also got a quick crash course in editing in Premiere, which I could do with as well, Enrique. So I'd be keen to learn that. So I'm going to skip this. I'm going to go through this in another time because I think a more valuable use of time, rather than me teaching you how to use LinkedIn, all I would say is it's good to go on it, because I put stuff on lectures out beforehand and crowdsource ideas. And we got some great stuff from Dr. Dean Eggett, who, if some of you have contacted me and said that you wanted to get involved in access to medicine, go on LinkedIn, add Dr. Dean Eggett, reach out to him. I'm sure he would be delighted to hear from you, because he does something called pre-medical school, which is about equipping people before they get into medical school, as in your stage, just before, how to get on board, how to help. They have a weekly class every Monday evening, I think, and I'm going to go there at some point and lecture. We just need to find some time in the diary. So thank you so much for listening. Let's move on to this worked example with M, who, remember when she was a housewife in the history taking session, the neurological clinical considerations? Clearly, we didn't tell you everything about M. She's not just a housewife, but you don't know unless you ask the questions. I want you to remember that whenever you next take histories from the people that we will bring to you in the additional sessions that we'll put on. So I'm going to stop sharing in a sec, but what we're going to do is we're going to do a live demo in the last 5-10 minutes. Haven't prepped this, haven't planned this, texted Em at 1 o'clock in the morning last night saying, would you like to do this? Thank you very much for saying yes. Story, create a story together, adding just one word per turn, can be about anything. Because we're going to stop the slides in a minute and we're short for time, we're going to try and go as long as we can and see what the story becomes. And I'd like you guys to think about how you found the task to watch, like we said, not just Em and I, how we feel. We will tell you how we feel afterwards, but how do you feel watching this? If you see something like this on the box, how does it make you feel viscerally? And the reason that we're asking you to do this is to understand how words represent individual thought processes, which may be difficult for the other to understand. And I'm laughing, certainly from my perspective, in the sense that sleep-deprived dyslexic with brain injury, recovering, this could be an absolute car crash. But I'm not going to turn it off. I'm not going to stop recording. I'm going to put it out there because I think it's important. So I'm going to stop sharing my screen and I'm going to try and get speaker view up. I don't know how that works. I'm going to, here we go, speaker view.
Top right-hand corner.
Sorry. Here we go.
Top right-hand corner of the box.
Nice one, thank you. So speaker view, here we go. So put in the comments, who do you want to start? I'll put it up to you quickly, but I'm not going to do a poll. We don't have time. Does it really matter, do you think? Do we really care? We're an hour and 45 minutes into this, or no, an hour and 15 into it. So I'll tell you what, ladies first. Go on then. Please say once, because at least it gives us a bit of a run in.
No.
Okay. Can I start?
Yeah, go on.
No, because I'm going to say once. I'm joking. Go on.
The.
Long.
And.
Short.
Of.
It.
Is.
Exceedingly.
Good.
To.
Express.
Clearly.
Cooperatively.
Collaboratively.
And.
This.
Experience.
Is.
Exceptionally.
Important.
As.
My head's hurting now. For. No, so what did you say?
As.
So this experience is exceptionally important as students
Deserve.
training,
In.
communication,
And.
teamwork.
Full stop.
Full stop. That's good. You can use. Oh, are we carrying on, or is that just the end of one sentence?
Yeah, full stop. Start again. Next sentence.
Next sentence. Okay. So
Capital
one thing.
letter.
Capital letter. No. Yeah, we laugh because I don't read any. As you will all know, whoever gets any messages from me at the various times of day that they come through, it's variable as to whether you will get a punctuated. If you ever get good punctuation, it's because I've dictated it. But anyway,
So.
what I thought was quite interesting in that, quickly, just before we do that, is when I was searching for filler words, they were very short, and it was is, that, because, and. because, yeah, I don't know why I was sort of searching for filler words. It doesn't really matter. But it was interesting to see how you then responded to that, and you drove it in that direction. In terms of, once I started giving longer words, then that thought process or that sentence came to an end. So, does anyone want to have a go? Because my head hurts. But if not, we'll do more. Paul, do you want to? Yeah, Paul wants to have a go. Where's Paul? We're going to do it, 3 of us. Is Paul still on the call? I hope he is. Giving him a shout. Oh no, he's gone. He's probably
Can't we do it with everybody? So we just.
Yeah. Okay. Don't worry about putting your cameras on.
Yay! Sarah's in.
Okay, Sarah. Okay, here we go. Fine. So I've got a screen that I can share here. Okay. If you want to put your cameras on, you can. If you don't want to put your cameras on, you don't have to at all. I'm going to share the screen. Oh, no, I'm not. So if you go to speaker, if you go to gallery view, we're going to run across the top. So it's going to be Em, Sarah, me, Lyd, Samrina, Alicia, Fizzer, Simon. That's the direction we're going.
I don't know if everyone's gallery view is the same as yours.
Okay.
I think it's different for everybody.
So it's going to be a mess. Very good. Well done. So let's have some volunteers then. So Sarah, Lyd, Em. If you want to do it, put your camera on. If you don't want to do it, don't. And then that'll help me kind of at least kind of moderate it. At the moment, it's just Em, Sarah, and I, which is fine. Okay. Samaya, hello, Samaya. Welcome. Who else? Natalia, if you're still on board and you want to give it a go, we'd love it. If not, no worries. Okay, fine. And you know what? It doesn't matter. I get you've got other stuff going on. I get you can do 2 things at the same time. And I get why some of you might not. Aha, Lucy, hello. And I get why some of you might not want to do this because it's hard work. But okay, so we're going to go Em, Sarah, myself, Lucy, Samaya. Em, Sarah, myself, Lucy, Samaya. Here we go.
1.
Sarah, just be off mute. It doesn't matter.
Did you say once? Or
Yeah.
did you say one?
1.
We. Wait, sorry. Did you say one or we? I mean, sorry, did you say one or once?
1.
1.
Once. We. Okay, sorry.
Went.
2.
So it's Samaya next. You're on mute though, Samaya.
Sorry, the.
So once we went to the
Elephant.
Park.
because
Because we were
Looking.
For.
Interesting.
Subject.
Full stop. Once. No. We started with once.
Yeah.
Then.
we
Saw a
Giraffe.
Stretching.
it's
leg.
so Samaya, can I ask why did you laugh? Because
I don't know.
I liked it too.
so
It was just
we saw a giraffe scratching its leg. What was it scratching its leg with?
no, it's just so random. That's why it's just like scratching. It's like I don't know.
But if you look at the chains of communication, you know it's random because I'm going to blame Em because she said elephant. So why don't we try and do this with okay. I'm going to try. Why don't we try and tell a story where we've all got a common theme or purpose, or we know why what we're talking about. So somebody give us a subject that we've got to talk about to direct the conversation around that subject.
Resilience.
Resilience.
Brazilian.
Okay, fine. So we're going to go. We're going to go. If everybody who's talking for this stays off mute, if there's other noises, Sarah, it doesn't matter because we need to be capable. We don't live in an audio sterile environment. And we're going to go Emma, Sarah, Sorry, M, Sarah, myself, Samaya, Lucy. M, Sarah, myself, Samaya, Lucy. Okay? Here we go.
Resilience.
People.
Often.
Don't.
Care.
Sorry, Lucy, what did you say?
Care.
So resilient people often don't care.
How?
They.
Are.
Perceived.
Perceived. How many of us on that thought the next word was going to be perceived? And Lucy, what did you think the word was going to be?
I thought there was quite a few things it could be, like how they're treated. They'll still like. Well, obviously they're going to care. So I don't know.
No. This isn't a criticism. It's because we're looking to see the fact that. So, from a cognitive diversity point of view, at that point, Sarah, Samaya, and I were a team of clones because we were all thinking the same thing. And if we were sitting in a business talking about what the next thing that we had to build or do was, we could be completely blindsided and waste a lot of money. So it's important that the person in the room who thought something else expresses what that was, because you don't have to express what that was, but can you see why the example in terms of why it's really important? So the next time you guys are on a call or on a meeting, or you're in a group work with students and your colleagues, and there's 3 or 4 loud voices all the time, the person that actually has a chat to the person that's not talking and just ask, well, what are you thinking? Well, you haven't said much. You're quite quiet. Could be just checking in from a pastoral point of view. Are you okay? Which is obviously important to do first and foremost. But then more importantly, even more, if that's okay, more important than that, is how do we make sure that we don't lose insight and intelligence from that person that could go on and kick off and find a cure to cancer? So on that note, thank you so much for listening. I'm going to stop the recording.